I've been asked to speak about celebrating excellence and innovation on this Bloodless Surgery Day. First of all, my disclosures. As Carolyn mentioned, I'm on the World Health Organization External Steering Committee to develop a global guide for PBM implementation, a WHO guide. And since 2008, I've been on the Australian National Blood Authority and the Australian Jurisdictional Blood Committee working group and CRG in developing evidence-based patient blood management guidelines. Seeing we're talking about excellence and innovation, it'd be good to actually define these terms. Excellence, so one of the definitions is the quality of being outstanding or extremely good. Innovation has been variously described as creativity is the ability to create new and potentially valuable ideas in any activity. Innovation is the process of transforming these ideas into reality, testing, measuring, learning, and sharing. Innovation is the creation, development, and implementation of a new product, process, or service, and note this with the aim of improving efficiency and effectiveness. Well, here are two men who exemplified excellence and innovation. Most surgeons will know of these two men, particularly cardiac surgeons, Dr. Alfred Blaylock on the left and Vivian Thomas on the right. They did groundbreaking research in the causes of hemorrhage and traumatic shock. Dr. Blaylock graduated at Johns Hopkins and was there. He met another innovator and proponent of excellence, Professor William Halsted. He was one of 4 founding professors at Johns Hopkins. And one of those being another innovator and proponent of excellence, Professor William Halsted, William Osler, or Sir William Osler, also referred to as one of the fathers of modern medicine. Now, all of these men made contributions to bloodless medicine surgery. How so? Well, Vivian Thomas, who was not a doctor, he was a young carpenter with a brilliant mind, brilliant hands, and love for medicine. And he, along with Dr. Alfred Blaylock, developed these surgical techniques to repair tetralogy of Fallot, or what was called the blue baby syndrome. This procedure is known as the Blaylock-Thomas-Taussig shunt, named after Blaylock, Thomas, and the cardiologist, Dr. Helen Taussig. So amazing is this story that a movie was made about it, an HBO movie entitled Something the Lord Made. The title draws from something that Alfred Blaylock said to Vivian when he observed the nearly undetectable suture line in one of the surgical procedures or techniques that he developed. And he said, "Vivian, this looks like something the Lord made." It exemplified excellence and innovation. The movie is described as an enlightening, emotional story of 2 men who defied the rules of their time to launch a medical revolution, a breakthrough that changed the face of medicine, a partnership that broke the rules. Does that sound familiar to what we're celebrating today? Here's the photo of them performing the first repair of tetralogy of Fallot. So here's Dr. Blaylock here and Vivian Thomas here. And many view this as ushering in the modern era of cardiac surgery. But who is assisting here? Well, someone we all know of very, very well, Dr. Denton Cooley, one of my earliest inspirations for my medical career. I had the great privilege of meeting him and I was invited to host him for his receiving of the SABM Presidential Award in San Diego in 2003. Of Vivian Thomas, Denton Cooley said, even if you'd never seen surgery before, you could do it because Vivian made it look so simple. That's what I took from Vivian, simplicity. There wasn't a false move, not a wasted motion when he operated. Excellence in his hands. Cooley was highly awarded and regarded for his excellence and innovation. But Dr. Cooley had amazing insights. He was a visionary. He observed things that we're only beginning to understand now. My colleague, Professor Axel Hoffman, and I had the privilege of organising to interview Dr. Cooley at the Texas Heart Institute that he founded when he was 92 years of age. And I'd like to actually play excerpts from this intriguing interview with him that really highlights his innovation and his observations that we can still learn from today. One of the first ones was the impact of Blaylock on him. Let's have a listen.
Well, Dr. Blaylock was an inspiring figure for me. He was more or less my role model in those early days. And I know that at the time when I was an intern at Johns Hopkins, my first assignment was to run the blood bank, and which I did for about 6 months. But some of my opinions about the use of blood transfusion began that early in my career.
So obviously innovators inspire innovators, and it does highlight the need for mentoring for future innovators. But what were some of the opinions that he developed about the use of blood transfusion early on? Let's have a listen.
I've always been rather skeptical about the compatibility of transfused blood with the recipient's blood. Well, it seems to me that the surgical profession and the medical profession too has always felt that the blood transfusion was just a simple sort of a medication or a measure that had no side effects. But in those days, it was my impression that blood transfusion was another organ transplant, and that the same rejection factors affected the blood as a transplant as would if you had a kidney or a lung or liver transplant.
So Cooley saw blood as an organ. Well, we understand more about this now. The microcirculation with its endothelial lining and the blood it envelops has been described as the body's largest integrated functioning organ system. Those in the field of proteomics have suggested that red blood cells collectively be classified as an organ because of the multiple functions they perform. About 3,000 proteins have been identified within each mature red blood cell. And as we can see here, there are multiple roles, functions of the red cell beyond gas exchange, including vasodilation, system metabolism, detoxification, and importantly, immunomodulation and cell crosstalk, cell signaling within the red cells and other cells. There's something else that another innovator, Professor James Isbister, commented on in 1978 when he said, blood is a remarkable juice, but this is only true while it is circulating within the living organism. So we know now that when blood is removed from its natural environment and placed in a foreign environment in isolation, it undergoes change. Most are familiar with the storage lesion, but there's really a collection lesion. There's a storage lesion, and there's a transfusion lesion at the point where it's transfused. And at each of these steps, there are multiple changes that take place. Some of them take place within minutes, others days to weeks. And so there's a lot of literature showing the changes that take place and the possible clinical consequences of this, including the pro-inflammatory and immunomodulatory effect of transfusion. This interesting study published in Transfusion showed that biological aging varies from donor to donor, and red cells from some donors age and deteriorate much faster than others. Red cells from some donors at the end of storage are biologically younger than those from other donors at the beginning of storage, and vice versa. This has implications for transfusion. Red cells are also large reservoirs of cytokines. This study identified 46 cytokines in red cells. That's many-fold higher than the plasma concentrations. And they highlight that these cytokines may be shared in mechanisms that are independent of hemolysis. So this too has implications for the adverse inflammatory immunomodulatory processes that follow transfusion. So what Cooley was seeing, we're getting a better understanding of, and there's a large body of literature now showing a long list of adverse outcomes associated with transfusion. And these associations are dose dependent. This shows some of the studies in trauma and critical bleeding, critical care, cardiac surgery, and other populations, very large numbers included in these studies. There's a consistent picture here that there's a dose-dependent relationship with transfusion and these adverse outcomes. So with every unit transfused, it increases the risk of these adverse outcomes. And similar results have been seen in studies looking at the impact of plasma and platelet transfusions, and again, a dose-dependent relationship. The outcomes of transfusion in cancer surgery have been studied extensively. So here's a list of some of the studies that have looked at this, the systematic reviews and meta-analyses of these studies. Here are the cancer types listed here. You can see the number of studies of the patient population. And again, there's a consistent picture here of increased mortality, overall mortality, increased cancer-related mortality, increased cancer recurrence, decreased disease-free survival, and increased postoperative complications, including infection. So Dr. Cooley saw these complications from an organ transplant very early on. We understand them better, but Cooley also came up with solutions to these problems. Here's one problem that he was working on very early on, where they saw complications associated with priming the cardiopulmonary bypass with allogeneic blood.
In the early days of cardiopulmonary bypass, that is open heart technique, using a pump and oxygenator, I was having difficulty in getting animals, maybe dogs, to survive cardiopulmonary bypass. I had been interested in some early reports about the question of compatibility of blood, particularly pooled blood. And I found that I had difficulty getting an animal to survive cardiopulmonary bypass for 30 minutes to an hour, and decided to try to not use blood to prime the system. We began priming the system with glucose solution, and the dogs tolerated the cardiopulmonary bypass quite satisfactorily. So I thought that now was the time to test this concept in patients. And when we then began doing cardiopulmonary bypass, priming this system with glucose rather than a pooled set of transfusions, we found that the results were much more favorable than it had been when we were using 6 to 8 units of blood in a pool to prime the system. That in the earlier days,
Dr. Cooley was presented with another problem, or rather a challenge, and that was patients requesting cardiac surgery without blood transfusion, patients declining transfusion. Now, Cooley saw this was a challenge, but he came up with a solution which involved excellence and innovation. And we all know this, as Dr. Usura mentioned earlier, that he's been recognized as the father of bloodless cardiac surgery. This is a time when large volumes of blood were transfused to perform open heart surgery, and it was considered impossible to perform cardiac surgery without transfusion. But Cooley felt these patients needed treating, and so he came up with a solution: bloodless surgery. In 1991, another innovator, Professor James Isbister, said that blood transfusion was previously seen as the gift of life, but the tables have been turned, and the general perception now is that bloodless surgery and the avoiding of transfusion may be the gift of life. Professor James Isbister in 2005 proposed the term patient blood management. And if you look at what he had in mind when he proposed this term, it's the same concepts that Cooley used in his development of bloodless cardiac surgery. James Isbister saw this as a patient-specific approach, and it was about managing the patient's own blood like any other organ or organ system, which is what Cooley did. He conserved the patient's own blood in order to improve patient outcomes. And so patient blood management is also now seen as a pragmatic solution to these problems with blood transfusion. And so, as already been mentioned, the World Health Organization came out with this policy brief earlier this year calling for the urgent implementation of patient blood management in all member states around the world. Also published this year, 26 experts representing 16 international societies published this global definition of patient blood management. And it acknowledges that this has its roots in the work done by Denton Cooley in the early 1960s and what would become a paradigm shift in practice. Renowned cardiovascular surgeon Dr. Denton Cooley pioneered what would come to be known as bloodless surgery to accommodate Jehovah's Witness patients' request for treatment without allogeneic blood. In doing so, his team applied one of the fundamental elements of evidence-based medicine. Now, how would you define evidence-based medicine? I've made a practice of asking medical students how they would define evidence-based medicine. And it's surprising that many describe this as practice based on clinical trials, randomized controlled trials. Is that the definition of evidence-based medicine? Well, here is the definition: the integration of best research evidence with clinical expertise and patient values and preferences. So intrinsic to the definition of patient blood management is patient values and preferences. Cooley saw this. He saw patients with a preference and he accommodated their preferences in innovating and designing or developing bloodless surgery. This takes us back to Sir William Osler. He said, the good physician treats the disease, the great physician treats the patient who has the disease. He said, it's much more important to know what sort of a patient has the disease than what sort of disease the patient has. So Cooley developed this three-step approach: optimizing patients preoperatively, using techniques to minimize blood loss, and he came to appreciate that patients can tolerate much, much lower hemoglobins than previously thought without resort to transfusion. And he regarded his bloodless surgery techniques as his greatest contribution to cardiac surgery. Now, this three-step approach that Cooley developed really developed into the three pillars of patient blood management, the same three-step approach to improve patient outcomes, and that's included in the WHO policy brief. If we come back to this global definition, you'll see again a similar theme here. Patient blood management is a patient-centered, systematic, evidence-based approach to improve patient outcomes as the goal by managing and preserving a patient's own blood while promoting patient safety and empowerment. Now, isn't this really the approach that Cooley took all those years ago? Patient-centered, managing and preserving the patient's own blood to improve outcomes. So Cooley in 1995 described his techniques, including the first pillar, to optimize the patient's blood prior to surgery. Listen to his comments about pillar 2.
Cut well, tie well, get well. In other words, you have to make incisions that are only necessary in length to accommodate the operation. You have to put a lot of attention to hemostasis. That's tie the bleeders off or else cauterize them. And then you can expect the patient to get well.
Cut well, tie well, get well, minimize blood loss. Another innovator and practitioner of excellence, protege, friend and colleague of Dr. Denton Cooley is Dr. Manuel Estioco, perhaps one of the most experienced bloodless cardiac surgeons in the world. And he followed in Cooley's footsteps. This is what he said: spending time in the operating room with Dr. Cooley had a lasting impact on my career. I was most impressed by his efficiency. Notice that word? Efficiency and effortless motions while operating in a relaxed atmosphere that only a master surgeon can muster. Well, Dr. Estioco went on to exemplify that in his practice of being in the operating room with Dr. Estioco on a number of occasions. This is a redo cabbage and valve replacement. And his signature was he practiced and he taught what he called white towel surgery. And you can just see the dry field, which is a hallmark of his excellence in surgical technique. Another innovator, Dr. Richard Spence, the surgeon should enter the operating room with the goal of preventing as much blood loss as possible by maintaining careful surgical hemostasis. Back to William Halsted, one of the first proponents of meticulous surgical hemostasis. To emphasize the importance of this, William Halsted once said, "The only weapon with which the unconscious patient can immediately retaliate upon the incompetent surgeon is hemorrhage." He really was highlighting the importance of surgeons being meticulous in their surgical technique to reduce blood loss. A famous British surgeon, Lord Moynihan, said the perfect surgeon must have the heart of a lion and the hands of a lady, not the claws of a lion and the heart of a sheep. Infinite gentleness, scrupulous care, light handling and purposeful, effective, quiet movements, which are no more than a caress, are all necessary if an operation is to be the work of an artist and not merely of a hewer of flesh. Blood loss is a problem. And so in the WHO policy brief, it highlights these adverse outcomes associated with anemia, blood loss, coagulopathic bleeding, and transfusion. Over 600 million individuals a year suffer from blood loss or bleeding disorders, major surgery, postpartum hemorrhage, heavy menstrual bleeding, GI bleeding, and blood being taken from patients in hospital. Vampires taking the patient's blood in large volumes and, of course, in trauma. What about the third pillar? Cooley had some very interesting observations about transfusion thresholds.
People have the idea that a surgical patient who has a blood hemoglobin level of 9 or 10 grams must immediately have a blood transfusion to bring his hemoglobin up to 12 grams. That's not necessary. I think 90% of our patients, even with their blood level down to 5 or 6 grams, do very well if you just modify their life and let their system take over the need for further erythrocytes.
Hemoglobins of 5 or 6 grams per deciliter, or 50 to 60 grams per deciliter. I don't know of any guidelines that recommend a transfusion threshold of less than 50 at this stage. And Cooley said this at a time where there was a transfusion threshold dogma that had developed. Transfusion was the default treatment for anemia, regardless of its cause, and it was based on a single arbitrary laboratory value, a hemoglobin concentration, which we know is not a good metric. Benefit was assumed. In 1942, this threshold of 100 grams per litre or 10 grams per deciliter was established. And if a patient needed a transfusion, he gave 2 or 3 units, not just a single unit. It wasn't until 1988 that this dogma of a hemoglobin threshold of 100 was challenged by the National Institute of Health Consensus Conference on Perioperative Red Cell Transfusion. And they actually recommended, based on physiology, a threshold of less than 70 grams per litre. Our group conducted this systematic review and meta-analysis of systematic reviews and meta-analyses of liberal versus restrictive transfusion threshold. This is called an overview of systematic reviews. It included 53 unique randomized controlled trials. It reported on 19 systematic reviews pooled by 33 meta-analyses. The primary outcome was mortality in restrictive versus liberal transfusion thresholds. In the meta-analyses graded as high to moderate level of grade, in 75% of those meta-analyses, there was no benefit identified for liberal transfusion thresholds. In 25% of those meta-analyses, it favoured restrictive thresholds, reduced mortality with restrictive thresholds. We conducted this large study in Western Australia to determine if there is a hemoglobin concentration where transfusion becomes effective, using an interactive model. This was the second in the top 10 articles in the journal Anesthesia that year. So we used this interaction model of anemia and transfusion surgical patients, and we looked at these various hemoglobin thresholds, comparing transfused patients with adjusted patients that did not receive transfusion at those hemoglobin levels. Over 60,000 patients from 3 major tertiary hospitals. These are the surgical populations we included, and the outcomes were mortality, in hospital 30-day and 1 year, and hospital length of stay. Now, if you look at this graph here, we could not find a hemoglobin value where transfusion was beneficial in reducing mortality. Up this end of the scale, at 90 and above, transfusion was associated with harm compared with patients not transfused. These are risk adjusted. Below that, we could not find a benefit even down to thresholds less than 60 that Cooley talked about. Now down here, the numbers got smaller, and so the confidence intervals are wider. But nevertheless, there was no benefit seen with transfusion compared with not transfusing patients with regard to in-hospital mortality. The same picture for 30-day mortality and the same picture for 1 year follow-up mortality. Harm this end, no benefit down this end. Length of stay was a different picture. We saw increased length of stay in patients transfused at every hemoglobin level down to a hemoglobin of 60 to 90. Below that, less than 60, no difference that we could see, no benefit. Coming back to this systematic review of meta-analyses of randomized controlled trials, what became apparent in this review is the wide variation in what is defined as liberal versus restrictive. And within the meta-analyses, there was wide overlap in those thresholds. And in some trials within the same meta-analyses, the restrictive threshold was higher than the liberal threshold in other trials. So these trials have limitations, and we need to be careful about their interpretation. There was one meta-analysis that was different, one by Salpeter, where they got a good separation between the thresholds. They only selected trials with a more restrictive threshold, less than 70, compared with liberal. They did a secondary systematic review of observational studies to evaluate even more restrictive thresholds, 30 to 60 grams per litre or 3 to 6 grams per deciliter. What they found with these more restrictive thresholds was decreased mortality, both in hospital, 30-day and total, reduced acute coronary syndrome, pulmonary edema, rebleeding, and bacterial infection was less in the restrictive threshold group. In their secondary analysis of observational studies, they concluded in surgical patients, the critically ill and patients with acute bleeds, hemoglobin levels of 50 to 60 are well tolerated when combined with supportive care. That's the thresholds that Cooley talked about, right? 50 to 60. They found no evidence of cardiac ischemia or inadequate oxygenation until hemoglobin levels decreased below 30 to 40 grams per litre. There's also numerous case reports in patients declining transfusion where clinicians have managed extremely low hemoglobins without resort to transfusion. Dr. Asuru published this one in severe obstetric hemorrhage and severe post-obstetric hemorrhage anemia. A hemoglobin of 1.3 grams per deciliter or 13 grams per litre managed successfully without transfusion. Other clinicians are starting to realize that the hemoglobin concentration is not a good metric to guide specific therapy. For example, Dr. Ivo Beverina has published on this. Now, this is in a patient where transfusion was an option and was acceptable to the parents. 13-year-old presented with a hemoglobin of 3.3 grams per deciliter. She had severe iron deficiency due to heavy menstrual bleeding. And the doctors decided not to transfuse this young girl, but to manage her differently with a good outcome. Then a 79-year-old female presented to the hospital with a hemoglobin of 3.8 grams per deciliter with cytopenic anemia. Now, she was asymptomatic with this very, very low hemoglobin. She'd been on PPIs for a while, a long history of rectal blood loss due to hemorrhoids. They decided to manage her without transfusion, again, with a good outcome and rapid response to hematinic therapy. This very, very interesting systematic review and meta-analysis was just recently published in Transfusion by Dr. Petrosiva and colleagues. Some of my colleagues were involved with this. where they were looking at mortality and morbidity in non-transfusible patients and transfusible patients. So this wasn't looking at transfusion versus no transfusion. This was looking at patients in whom blood was not an option and patients, matched patients, where transfusion was an option. Here's the meta-analysis looking at mortality. As you can see, there was no increased mortality in the non-transfusible patients. The odds ratio is 0.87. Now, it wasn't significant, and yet you look through these and the point estimates are rather interesting, but this is reassuring, no increased mortality. In the secondary analysis, meta-analysis of secondary outcomes, you can see looking down this right-hand side here, there was no increased morbidity involved with patients that were not transfusible or where transfusion wasn't an option compared with those where transfusion was an option. Interestingly, if you look at infection, acute myocardial infarction, reoperation, there was a trend towards reduced infection, MI, and reoperation. Not significant, but a trend towards that. This was, however, significantly different. The length of stay in intensive care in the non-transfusible was significantly reduced. They also did a subgroup analysis of patients with severe anemia and hemorrhagic shock. And again, there was no significantly increased mortality. So the authors concluded the results may reassure clinicians that observational studies of low to moderate risk of bias indicated patients unable to receive allogeneic blood transfusions have similar clinical outcomes and in some instances may have better outcomes than patients able to receive transfusions. Patients considered non-transfusible were treated at similar or reduced hospital costs, which is also interesting. Such was the interest in this meta-analysis that the authors were invited to present these outcomes to the US Food and Drug Administration, or FDA, journal club just recently. So what about outcomes? Let's listen to Cooley's observations with his approach.
One critical group of patients were people who refused to accept blood transfusion. This was a religious group known as the Jehovah's Witnesses. And I could compare those patients who had no blood products whatsoever with another group of patients who underwent conventional sort of blood replacement. And the results seemed to be better in terms of morbidity and mortality among those patients who had refused blood transfusion.
So his impression was patients did better with this approach. So coming back to what we're celebrating, excellence and innovation, particularly looking at this aspect of innovation, transforming these ideas into reality and creation, development, and implementation of a new product, new process, or new service with the aim of improving efficiency and effectiveness. The World Health Organization policy brief reproduced the infographic of the results of the West Australian Patient Blood Management Program that I was involved in designing and implementing. This was the world's first health system-wide, public health system-wide patient blood management program. It started off in the state with the lowest red cell transfusion rate in high-income countries. So there's already a very conservative approach to transfusion where we started this program. When I approached the director of the Red Cross to explain what we're doing, he said, "Why on earth are you starting here? We already have the lowest transfusion rate in the world." But we said, "We think we can do better." And this program was basically built on the same three-approach strategy that Cooley developed over 60 years ago. Talking about excellence, innovation, efficiency, effectiveness, this program saw increased effectiveness and efficiency. So despite having a very low transfusion rate to start off with, we saw a 41% reduction in blood transfusion, 41% for red cells, 47% reduction in plasma, and a 27% reduction in platelets. Now this is across the whole hospital population: trauma, obstetrics, burns, surgical, medical, haematological patients, transplantation patients across the whole range of patients. Reduced transfusion with improved outcomes. 28% reduction in mortality, infection reduced by 21%, AMI stroke by 31%, and length of stay 15% reduction, with significant cost savings, up to 80 to 100 in estimated activity-based costs or blood product activity-based costs. So increased effectiveness with increased efficiency, all based on what Cooley pioneered all those years ago. This book has just been announced. 48 international authors contributed to this publication. There's a chapter on pediatrics and neonatology, and there's a chapter on women's health, the topic of this Bloodless Surgery Week. The authors in this chapter said PBM is well established in adults and is recommended by international experts as a new standard of care. Unfortunately, its acceptance as a standard lags in the care of babies and children. The implementation of PBM in neonates, infants, and pediatric patients is seen as an urgent, unmet medical need. The chapter on women's health, the authors state, this approach can improve outcomes for women, mothers, and babies. PBM is well established in other areas of medicine and surgery. However, there is still little awareness among primary care physicians, emergency department physicians, hospital doctors, obstetricians, obstetric departments, and gynecologists of the importance of PBM in improving women's health. Here's the problem. It's estimated that 1 billion women around the globe suffer from anemia. An additional 1.2 billion, it's estimated, suffer from iron deficiency without anemia. Both of these are associated with adverse outcomes. So 2.2 billion women possibly suffering from iron deficiency and anemia. And anemia has been identified as the leading cause of years lived with disability in females. Maternal health and child health is a real need. There's a real need in this area. And that's why this week is devoted to improving outcomes in maternal and child health, employing the principles of bloodless medicine. Coming back to the WHO policy brief, there is this call to action. All member states should act quickly through their ministry or Department of Health to adopt their national PBM policy, install the necessary governance, and reallocate resources to improve the population health status and individual patient outcomes while reducing overall healthcare expenditures. This article in the New England Journal of Medicine, A Glimpse of the Next 100 Years in Medicine, said the era of shifting more and more economic resources toward healthcare is going to end. The medicine of the future will focus on more efficient use of resources. Is Bloodless Surgery Day worth celebrating? Certainly is, because it celebrates excellence and it celebrates innovation, with the aim of that is to improve efficiency and effectiveness, improve patient outcomes while reducing costs. Thank you very much for your kind attention.